Hello, friends. I'll be talking on this Molnupiravir NEJM trial. I did touch about this briefly in the previous talk in the 57th update. So today I'll be just dwelling into a bit of a detailing of this article since it's going to be practice changing sort of a article and more so in the light of possible third wave that may be coming through. So we just need to know the whole details of how this trial was conducted. So this was a phase 3 double-blind randomized placebo-controlled trial. So here they compared Molnupiravir with placebo, and Molnupiravir was used within 5 days of onset of symptoms and signs. So this is very important because the inclusion criteria was to have patients enrolled within 5 days of onset of symptoms and signs. And another important aspect is they took patients who were not vaccinated. So in India, predominantly, we may have population which may have be vaccinated. So we do not know for sure how effective or whether it's going to be significantly effective in vaccinated population because this study included patients who were unvaccinated. They were non-hospitalized patients. Along with this, interestingly, the newer trials that have come, even the remdesivir OPD trial, has taken high-risk population. Even this particular study took patients with one of the risk factors who would have progression of the disease. So they took patients who were more than 60 years, who were obese, or who had one of the comorbidities like heart failure or diabetes. So they took patients only with comorbidities having one of the risk factors as one of the criteria. And the primary endpoint, they looked at patients needing hospitalization or death until day 29. And they looked at safety endpoints. For the safety endpoints, they looked at the adverse events between the Molnupiravir and they looked at it as one of the endpoints between Molnupiravir and the placebo group. So the secondary endpoint, they had a scale of 11-point clinical progression, and they looked into how the clinical improvement happened over this 11-point clinical progression scale. And for this, they looked at the time taken for the sustained resolution of symptoms and signs from the day of randomization and until the day when the symptoms started improving. So they took the number of days that it took for the symptoms to start improving, and they even looked at whether this improvement was consistent on day 1, day 2, day 3. So it's a very important. So they had put in fair amount of effort to see whether the improvement or alleviation of symptoms was sustained and how many days it took for this to begin. And on the same accord, they even looked at whether there was any worsening of the symptoms and how many days there was between the randomization and how many days it took for the worsening of the symptoms. And even that they looked at day 1 and day 2 worsening of the symptoms. So this was the secondary endpoint they looked. And the exclusion criteria in this trial was patients who were hospitalized within 48 hours were excluded, and patients who were on hemodialysis or who had a glomerular filtration rate less than 30 ml per minute, or who had neutropenia with absolute neutrophil count less than 500, and thrombocytopenia and pregnancy. So these were some of the exclusion criteria. And this was a big study. They had 107 sites across 20 countries when they did this study. And they found overall females were more in the Molnupiravir group. And the percentage of patients who had signs, as I said, they took patients who had symptom onset within 5 days. And there was a significant proportion, 47.7% of the patients who had signs and symptoms less than 3 days. And moderate COVID was present in 44.5% of the patient population. So as I said, they took patients who were more than 60 years and who had comorbidities or who were obese. So the significant proportion of patients in this particular study, which constituted risk factor was obesity, which constituted 73.7%, followed by more than 60 years was 17.2%, and diabetes was present in 15.9%. So even they looked at baseline antibodies. So if you look at the recent studies, even if you refer to the antibody cocktail video I had done, so they do the baseline antibodies to ascertain. So one of the concept or one of the understanding they have is if the baseline antibodies is negative or low, then the understanding is the viral load is more and the severity would be more. If the baseline antibodies are present or high, it means the viral load is less and the symptom severity would be less. So this is the sort of understanding they had in antibody cocktail. So I think even here they looked at the baseline antibody. So here they looked at antibodies to the nucleocapsid, helical nucleocapsid, and it was present in 19.8% of the randomized patients. And there was no sequencing to ascertain. So sequencing also was done in more than 50% of the patients to determine what strain of virus was present in these patients. So in about half of the patients, so there was no sequencing done in 44.7%. And when you look at the breakup of the strains, the Delta strain was present predominantly in 58.1%, followed by the MU strain in 20.5%, and followed by the Gamma strain, which was present in 10 points. So none of the patients had Omicron because this was done prior to Omicron's onset. So predominantly it was the Delta strains that was present in this particular study. So when they looked at efficacy, so the need for hospitalization was 31% lower in the Molnupiravir group, and the risk of death was 89% lower in Molnupiravir. And clinical progression scale, which they looked at the 11-point progression scale, they had improved outcome in the Molnupiravir, and this improved outcome was more significant at day 10 and day 15. And there was a sustained, as I said, it was the time taken between the randomization and from the onset of symptom alleviation. So there was sustained abatement of symptoms that was more likely in Molnupiravir, which means that once the symptoms started receding, so it persisted, and there was no resurgence or recurrence of these symptoms. So sustained abatement was more likely in Molnupiravir, and clinical worsening was less likely in the Molnupiravir group. And even it was found that the viral load, when they measured, there was a greater reduction in the Molnupiravir group. So this is a forest plot where you see this is the Molnupiravir group. The viral reduction, as you see, was lesser as compared to the placebo. And if you look at this confidence interval, that was statistically significant, which means there was a greater reduction in the viral load when they checked between these two groups in the Molnupiravir group. And when they compared the adverse events, the progression of pneumonia or worsening of pneumonia happened in 6.3% of Molnupiravir and 9.6% in the placebo, and diarrhea 2.3 in Molnupiravir and 3 in placebo, and bacterial pneumonia 2% and 1.6, and worsening COVID happened in 7.9% in Molnupiravir and placebo 9.8. So these were the distribution of the adverse events, although there was no great statistical significance between any of these adverse events. So this is the important aspect. So the uniqueness of this study was there were two analyses that was done. So they did an interim analysis halfway through the study, and then they did the analysis of all the patients who were randomized at the end of the study. So at the end of half recruitment, they did an interim analysis, and then they compared with whether this effect continued to be present even after full randomization. So this was a little uniqueness of this study. So the interim analysis was done with half of the patients, 762 patients, 385 in the Molnupiravir group, 377 in the placebo group. So as you see, the risk of hospitalization and death was 7.3% compared to placebo of 14.1%. And the point difference was minus 6.8% point difference was present between Molnupiravir, and they looked at whether this point difference remained the same or this point difference reduced in the full analysis, and that's what we would see. And that was statistically significant. Adverse events was 35% in Molnupiravir and 40% in placebo, not significant. Then they took all the patients who were randomized at the end of the study, which constituted 1,433 patients. And this is interesting. So if you look, the risk of hospitalization and death, it remained significantly less in Molnupiravir, 6.8% as compared to 9.72%. But if you see the point difference reduced from 6.8 point difference, which was a much larger effect that was found in interim analysis, the effect size diminished to minus 3% point difference. So this one could argue. So the authors in the discussion do mention this point difference only indicate that the patients who were randomized probably had a clinical progression towards getting better, and possibly that is the reflection of it. But one school of thought would say when the whole randomization happened, there was a reduction in the effect of this molnupiravir. And had you possibly increased the number of patients to more than this, possibly this would have not have attained statistical significance. Some school of some people who would argue on that. So, but what one could decipher is there was, as the number of patients recruited increased, the point difference reduced. So which possibly raises little concerns whether if we involve a lot more patients, whether the statistical significance would disappear is what one could argue. And the deaths, if you see overall, there was 1 death in molnupiravir and there were 9 deaths in the placebo group. So this was the uniqueness of the study, where they did an interim analysis halfway through the study, and then they did the full analysis and saw whether the effect size remained the same or whether the effect size diminished. And as you see, the effect size did diminish. But the way authors argue is there was a clinical progression towards getting better in these patients after few days, and there was an overlap of this, and that's what was reflected in this point difference. So you could interpret in any ways, but these are the two schools of thoughts that remain. So in the discussion, so the authors conclude molnupiravir administered less than 5 days of symptom onset reduces the risk of hospitalization and death at day 29. And molnupiravir from this study was found to be effective against all 3 strains: Delta strains, Mu strain, and Gamma strain. And predominantly, there were more than 50% of the patients were Delta strains in this particular study. And in the subgroup analysis, they found this molnupiravir possibly was found to be less effective in patients who had previous SARS-CoV-2 infection, or in patients who had a low baseline and viral load, and diabetic patients. So this was something that they noticed. And here, interestingly, they compared the placebo group comparison, because one would argue why one would use, whether one would argue whether the antibody cocktail is better than using this molnupiravir. So here they looked at comparison between antibody cocktail and molnupiravir, and what they found was they did a placebo group comparison and to see how sick the patients were. So what they found is, in the placebo group, the risk of hospitalization and death was lesser in antibody cocktail as compared to molnupiravir, which denotes this is in a placebo group. They found the risk of hospitalization and death was more in the antibody cocktail. What it tells you is placebo is where there was no interventions, that they had much less sicker patients as compared to this particular study, where the sickness quotient was much higher. So, and who possibly had a higher risk of disease progression. So basically trying to say there is more merit in this study because the placebo group had higher risk of death, indicating that these patients had a higher risk of progression of the disease. And in this group, intervention with molnupiravir had a better effect. So that's what the authors tried to substantiate. So that was about this whole study. And as any practice changing study that comes, there was a good editorial that came in the same paper by Richard Whitley, where there are a lot of queries raised about the molnupiravir. So the questions raised or queries that possibly remain unanswered is how effective would molnupiravir would be if it is administered more than 5 days. So we do not have an answer. So as you see in this particular study, close to 50% had got molnupiravir less than 3 days, or the randomized patients were less than 5 days. After 5 days, whether the effect would remain the same, we do not know. And there is a concern raised about molnupiravir's mechanism of action. We know it causes viral error catastrophe, which means it induces anomalies in the RNA sequencing, which means it induces mutations. So the concern about its mutagenicity and genotoxicity is something that raises the concern. And this concern was sort of assuaged by the author, saying that there are phase 2 trials did not show this effect to be very significant, is what they substantiate. And we do not know whether molnupiravir can be used in pregnancy, because we know for that remdesivir we were using for pregnant also in the later part of the disease, but we do not know about how safe it is in these pregnant ladies. And the other uniqueness of this study is this molnupiravir was used in unvaccinated, so we do not know how it will perform in vaccinated, because in India at least majority of the population, significant population, have got the first dose of vaccine. So they do not fall in this category of unvaccinated, and we do not know whether it holds promise in vaccinated patients. And most importantly, authors do suggest that Molnupiravir as opposed to antibody cocktail, because antibody cocktail may be less effective against Omicron, because of which antibody evading action. And here the authors say Molnupiravir may have a better role because it may be effective against the Omicron virus as opposed to antibody cocktail. So, but that remains to be seen because we do not know for sure how effective it would be against. But scientific plausibility says that it should be very effective against the Omicron as well. So that's about it, friends, about this study. So it is a well-conducted study. It's a good study. And although from the interim analysis to the full randomized study analysis, the effect size sort of comes down, but still it maintained its significance, and the study, uh, the power calculation was done, and the numbers that was meant to be recruited were almost recruited, because 1,500 was what the number they had. It fell a little bit short, but it still maintained its power. So all in all, so Molnupiravir is something that as clinicians, we wish to possibly use it and see whether it holds promise, because really we would want to intervene very early on and to prevent progression of this disease into inflammatory phase, needing hospitalization and burdening our healthcare. So thank you, one and all.